So welcome to Selling to the NHS, where we're going to focus on three things: culture, commissioning, and contracts. Three really big things, and we're going to try and do it in an hour. The next slide. So here's the agenda and the speakers for today. Can everyone hear me okay, Phil?
Yep.
Good, okay. So commissioning in the NHS, that's going to be covered by myself and Tony, and we're also going to have some culture slides in there at the beginning. Then we're very lucky to have Jim and Mike, I think, is joining them as well. They're from the Lancashire Procurement Cluster, so they know everything good and bad about procurement in the NHS, and they're going to help you understand it. And then we're very lucky to have someone who's worked in the industry, been the chair of the Academic Health Science Network, and now works for a trade body. So Richard will be presenting at the end. We are recording this workshop, and we can share it after today's event, both the people that come and the people that couldn't make it. I think we're turning cameras off, is that right, Phil?
Yes, please.
And just raise your hand if you have a question at the end of the different sections, or put something in the chat, and kindly my boss Mike is going to manage that for us. Okay, so let's get to the next slide. Not going to believe it, Phil. I'm stuck on that slide there. Right, here we go. So what's the culture of the NHS like as an industry? So we're going to put a question and hope that it'll work. If you're already selling to the NHS, and what I mean by that is you've got a contract, more than one contract with the NHS, just say yes. If you haven't got a contract with the NHS, just say no, because I want to get a feel for the audience I'm speaking to.
1 second, sorry, it's just loading.
Has that question popped up yet?
Should be on the screen now.
Does that come through to you, Mike and Tony?
Yeah, we can see that. So,
okay.
Yeah, just remind people what you're asking them to do.
So what I want to know from the audit delegates is, are you already selling to the NHS? So my definition of that is not trying to sell, but you've actually managed to secure a contract or two. And if you haven't got a contract with the NHS, just answer no. We just want to see what the split in the audience is. Starting with technology, always a risk, but hey, worth it. So nearly 60% saying yes. Is that right?
Yep.
From 40 people? Great. Okay, let's get started. So the NHS, so there's a bit of truth here. There's 30 years of my experience and colleagues' experience with the NHS. It is a monopoly in the NHS and in healthcare, but it does not think and act like one, right? That's the first thing you've got to appreciate. The absence of competition means there isn't a culture of customer service or choice. We're not beating the NHS up here. We're just helping those who haven't sold to the NHS be prepared for what it's like selling to an organisation that does not think and act commercially. It's highly regulated, it needs to be, but that makes it risk averse. And we're largely driven by compliance. And obviously, a lot of industries are driven by compliance and commitment. Sorry, Phil. We're actually paid for activities, not outcomes. And if I was going to use an analogy, that would be like paying for an airplane to take off on time, not paying for it to land safely. So we're not paying for outcomes. Although there's a small payment, it's small. My wife, who's on a board of directors at Northern Care Alliance, has said this many times over the years. It's an over-managed industrial system and under-led. These aren't criticisms, by the way. These are observations of experts like myself and Mike and Tony and my wife and others who've been selling to the NHS for a long time. Staff don't think like a patient or act like a taxpayer. Patients are largely passive. We don't want them to become like the American system, but I do think they will become more discerning. That's important when you think about your product. Prediction, precision, efficiency, and safety, a bit like Formula One, are all really important. So if your product does one of those things or two of those things, you're probably onto something. So how do I describe to my neighbour what it's like selling to the NHS? It's hard. It's slow. There's so many doors, and sometimes you don't realise you're going through the wrong one. And we never run out of red tape. We will tie you up in red tape until you trip over. Not us, but a collection of different organisations. So there's a lot of committees. So sometimes your product will bounce around committees for discussion where you're looking for a decision. There's a lot of acronyms. Don't be afraid of that. We're never bothered when someone says, what does that mean? So make sure if someone uses an acronym like Academic Health Science Networks, ADHD, or anything like that, you just ask what it means. People will always be interested in the NHS, but that's quite hard to convert that to intention. Now, the good news is, I've just told you how hard it is, right? That's why we're here today. Me, Mike, and Tony, Jim, and Richard, we exist so that we can help make it less hard for you if your product's market relevant. 2 more questions if we can. So of the 60% of people that said they were already selling to the NHS, do you agree with my last 5 slides? Me being honest, me being candid, telling you the truth about the NHS. If you're already selling to the NHS, do you agree with what Steve's just said? I should get 3 yeses at least from Tony and Mike.
I've cast my vote, Steve. I've cast my vote.
Well, you can go left to Labour or you can stay. How many we got there? 26 responses. How many people we got on the call here? 61?
Yep.
Come on. I mean, all right, half of you voted, but the majority are saying you don't disagree with me, which means I can stay. I actually can carry on with this presentation, although you'd be delighted to know I'm about to pass the baton over. Right, for those of you looking at my ugly face who aren't selling to the NHS, are you surprised by what I've just told you? Do you want to throw that question up for them, please, Phil? Twenty responses. Come on. No, it's a no. Okay, good. So you know what you're dealing with. Right, Tony, are you ready? After this slide, I'm bringing you on. After this slide, I'm bringing you on.
No problems.
I love this picture because it's the top of Everest. Doesn't that look like an easy journey to go on? Perfect weather, not much of a queue. You're nearly there. I'd actually say it's easier to climb Mount Everest, even though I've never done it, than to sell to the NHS. Not trying to do myself out of a job here. That's why me and Mike and Tony can help you get to the top, because that's where the checkbook is. Right, over to Tony, who's our exec director and has a commissioning background.
Yeah, good to meet everyone, and a great turnout. This is the first time I've helped Steve with one of these areas. Just a bit of background. For me. I'm director of business development at Health Innovation North West Coast, but I spent the last 10 years really as a director of commissioning, mainly in the Merseyside system. I was director of commissioning for Liverpool and Knowsley CCGs. So I'm going to talk a little bit about it. A lot of this is drawing on my personal experience as a director of commissioning and what was expecting. I'm very conscious the procurement guys are coming on from Lancashire and South Cumbria, so I'm going to touch on the structures, but I'm not going to cover any specific areas on Lancashire and South Cumbria because I'm not as close to it as the likes of Jim, etc. So essentially process, and Steve, if we can go to the commissioning cycle slide I sent across.
Yeah, I'll have to bounce forward for that. Hang on.
Oh, hang on. Right, okay. Yeah, that's the one. So this is what we call the NHS commissioning cycle. And I wanted to just, I haven't worked in, I left the CCG in 2020, which is now the Integrated Care Board. The CCGs got changed. So in Lancashire, South Cumbria, I think they went 5 CCGs to 1 Integrated Care Board. But actually, the commissioning cycle is still really relevant to us. And it's not just the NHS who operates on a commissioning cycle. These commissioning cycles are in operation for local government, for any government area really, and in industry. You know, the likes of British Aerospace will have their own commissioning cycle, their own contracting cycle. So this is still really quite relevant to us at the moment. And what you'll see within this is, it is about putting patients and public at the heart of this, but I think Steve's point is really correct, is at times, even though we're all patients, we're all members of the public, when we're in a job, sometimes we forget, and we forget that we are, how we're acting as a patient, as a taxpayer. So the guys are going to talk the turquoise area around procuring services. The guys are going to cover, so we're not going to go into great depth around that particular area. So I'm going to start in the red area. This is a constant cycle for NHS organisations, that they're constantly strategically planning a number of years ahead. Now, and that essentially means is they're constantly looking at what needs are in the system, what do the public need, do the services meet those needs, and what are the priorities moving forward. So I think the key message around that at times is, and this is where in particular Steve and the team really help, is that assessment of, is what you're bringing going to meet need? Does it have, you could have the best innovation in the world, but if it isn't what the buyer needs at this particular time, then you're going to struggle. And that's where the guys can really help in that regard. Once you've got that sort of strategic vision and planning, it's over into and this is where the procurement team really help in terms of looking at the structure of supply, planning different capacity and services. Well, I'll leave that a bit to them. The other particular elements around the commissioning cycle are around that constant monitoring and evaluation of what is working and what isn't working well. So, and the relevance I want to put on this one for you guys, and I noticed there was about 50% who are already selling to the NHS earlier. So the key element around that, and I'm just reflecting a little bit on a meeting me and Mike was at quite recently, where the medical director, Steve Powers, for the NHS was talking to innovators, and essentially saying is, no matter, even if you've got a contract, what you've got to demonstrate is impact. So that evaluation of how something is working in that real world setting, and we've got the data, and that data needs to be independently verified. It is no good as a company just producing your own company's data. The NHS won't make a business decision based on that. It'll want real world evidence of where this has been put in place. Having said that, what I am going to say is that looks wonderful on paper. Because of the pressures sometimes facing the NHS, it doesn't always follow that process to the and quite often things feel a bit more chaotic than that. However, what you guys need to do is understand the sort of context that you're working in, and the context that you're working in, and how you can bring your offer in an attractive way that it can help navigate this planning cycle. And the one biggest thing I would say, and I'll just reiterate this, the key element is the evidence that something works. You're probably going to get a bit frustrated with the NHS at times, because what it will do, and this is probably a consequence of the finances, but the financial situation in the NHS as a whole. But again, this is where our organisation will try and challenge some of this for you as well, which is what we suffer from at times is pilotitis. So you could have a great piece of evidence that you've implemented something in Leeds and it works, and you've got an independent evaluation that shows it works, and you'll come and try and sell to the local NHS, not just in Lancashire, South Cumbria, anywhere, and they'll say, can we do another pilot, please? That's a challenge, and we are actively trying to work against that and actually saying, well, how many more pilots do you need? The population isn't different, but it is something you will come up against, and it isn't always possible to break that down. The other area that we do see quite an awful lot of is a little bit of unrealistic expectations. I had a conversation with a company recently who've been doing a project in a different ICB area, but they were this was around about December, and they were saying, yeah, we're hoping to get a contract in place by April. And I was saying, have you got an evaluation? And no. And I was saying, yeah, you've no chance. You've absolutely no chance. And they said, no, the ICB's told us they're going to give us a permanent contract, a 5-year contract in April. And I'm like, well, I can't see how they will. So there is just something about the naivety and understanding the NHS commissioning cycles, because generally you start planning for the year ahead around about October. And essentially, if the funding isn't in place in October and the contracts aren't being negotiated from October through to December, it isn't happening for April. The best you're probably hoping for, if you're already selling into the NHS, is an extension of your current pilot for another 12 months while more data's gathered and a business case produced. And if you haven't got that, if you haven't already got an existing contract, you're going to be asked an awful lot about more data and potentially a 12-month pilot. So that's not to be all doom and gloom, because sometimes that can be, is getting a 12-month pilot in the NHS or an extension can be, quite a result. And the secret to the NHS is once you break it, it is possible, it's possible to scale. It could be, once you've demonstrated something really works, you've got the ability to actually, the biggest organisation in the country, the biggest employer, by far the biggest funder. The last point I'll probably make, and I will come back onto the ICBs, is again, I'm going back to a quote that Steve Powis did, and Mike heard this the other week, is I think one of the biggest problems we hear is people believe the NHS is a single organisation, and it isn't. The NHS it's just a concept of numerous different organisations underneath it, hundreds and hundreds of different organisations. And as the medical director put it, Steve, he was saying you've got to look at the NHS as almost a flotilla of different organisations, all hopefully moving in the right direction. But at times you do get the odd ship trying to change direction and go in a different way. But that's one of the other big takeaways, is you have to understand that when you're working with they're working to an entirely, what's gone before. Selling once to the NHS doesn't mean you're selling to everybody in the NHS. And if you just go back a little bit, Steve.
Yeah, I was just going to say, we've got that video I'd like to show as well. It's 4 minutes.
Yeah,
long.
Please do, mate. Yeah, if you want to do that.
Either Phil, Tony, or Mike, tell me if the sound comes through.
Yeah.
Okay, great.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular and ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health, and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents, and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aimed to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they have existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care
That stopped.
Yeah, it stopped.
sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
So 2 more minutes. Tony, if you can just...
Yeah, no, I probably just that's been really helpful, that Steve. And actually, I just want to sort of and I know all this is being sent out. And there's another couple of slides in the pack here which sort of explain how this comes together in a diagram and then how it looks at Lancashire and South Cumbria. The bit I want to reference is, and I have to say that's the first time I've seen that video from the King's Fund, but really helpful. But there's a bit right at the end where is integrated care boards and integrated care systems. They're not going to fix everything overnight. We've come out of a global pandemic. You only have to read the news to see. I was talking to somebody today. The northwest of England, if you add up the 3 ICB's deficits, it's £500 million. So it's starting the year with £500 million worth of deficit that it's got to fix. Now, within that is obviously we've got to innovate our way out of that as well. So it isn't an immediate fix. And I have spoke to a couple of companies who are going, well, we're dealing with the ICB. They're the decision maker now. So, everything should be easier, shouldn't it? I don't think it is going to get any easier for a while yet. I think it's going to be tougher. It's still tough to navigate. But I'm just going to sort of think, this is where we would look to support you and help and be that bridge between the local health systems who genuinely do want to make a change. They need innovation, they need support, but are also dealing with some really tough challenges. And you guys who also have your challenges around how you take a small to medium enterprise and you've got a great idea, you've got something that can make a difference, you want to get it to market. So I'll finish there, Steve.
Yep. Just to say, this slide is just a one-pager of what you've just seen in the video. The next slide is just, we won't get into it, and that's the link for it. This slide shows the breakdown of NHS spending, and we've done the cycle. So now, thanks for that, Tony. If Jim and Mike are ready.
Indeed, Steve. So afternoon, everybody. My name is Jim Collins. I'm currently head of procurement at Morecambe Bay and North Cumbria, but I'm about to move into a new role on the 3rd of June, which is Chief Procurement Officer for Lancashire South Cumbria, and that's one of the ICBs that's been referred to earlier. I'm joined today with my colleague Mike Doyle. Mike, do you want to give a wee overview yourself?
Yeah. Hi everyone. Yeah, I'm Mike Doyle. I'm the Deputy Director of the Lancashire Procurement Cluster. The LPC itself is 7 years old. It was formed as a shared service for Blackpool Teaching Hospitals, East Lancashire Hospitals and Lancashire Teaching Hospitals. So that's 3 of the 5 provider trusts within our patch effectively. And as Jim's just alluded to, we're bringing the 5 providers together under the banner of one LSC, one Lancashire and South Cumbria procurement shortly, which is great news.
It is. So that was quite sobering, if you don't mind me saying, Steve. And I'm looking at Mike's face, and he's obviously the same as myself. So I think we recognise as procurement leaders within the Lancashire South Cumbria ICB that actually selling to is getting ideas to market for all the reasons that have been highlighted by Tony and Steve are real and genuine. There's no two ways about it. Mike and I both passionately believe that the procurement can be a really good conduit to break down those barriers to help us. And a lot of the changes that Mike's alluded to in terms of us coming together as a procurement one team and one system across a fairly large geographical area is specifically designed to break down those barriers. So hopefully as we go through this sort of presentation, very, very high level presentation, we're looking at two areas to try and get people across to. We want to give you an insight into ourselves in Lancashire South Cumbria. As Tony said, our deficit purely in Lancashire South Cumbria is about 190 million. So that you know, that's driving significant structural change, transformational change, and I suppose from that there's an opportunity, and certainly that's what Mike and I are trying to exploit. There's an opportunity for us to influence that and to help with that deficit, and transformational innovation products and accessing new suppliers is going to be key to that in the non-pay spend. It won't solve the problem, it generally won't, but it will make a significant contribution, and for us that's all we can ask for. And the second thing that Mike and I want to sort of finish off with is as we get through, and we promise there's only 7 slides, as we go through them, at the end we wanted to give in essence a flavour of actually how to find out what we're buying, and Tony alluded to it, what we're buying, how you can keep contact with that, and actually how do you access that knowledge. However, one of the key themes on this presentation is very much around, we want to offer those personal connections because that's how, because the risk for us as a body in NHS is huge. I can't downplay that, and that does dictate our behaviours and does dictate how we approach it. However, we see, as I say, we see procurement as the conduit to make some of those changes. And so what Mike and I are kind of offering today, really, if you like, is we want to make those connections more personal, because we can walk through and provide that support and help for opportunities. So hopefully as the presentation unfolds, Mike and I are just going to kind of interchange as we go through it, then that'll make perfect sense. So we'll probably cover this one, but this is quite an important one. The picture is probably the most important thing here. I think Tony spoke about it, and you can see from the diagrams and the small video how complicated it can be. I personally like this photo because the lady in the chair is starting her journey, and what we're trying to do for the first time in procurement as a system is to cover everything in terms of what that patient would need from their journey, from going to see the GP at primary care, straight through to maybe support in community services after treatment and possibly one of the acute hospitals. And I think that sums up everything we're trying to do. And so in essence, it was really interesting listening. I think it was Steve said it about how do we improve outcome, patient outcome every pound we spend, and that's about actually, it's moving away from, or we're trying to move away from what Steve was saying about it's about activity we're paying for, not outcomes. We have a number of contracts, not huge, and that's really important, but a number of contracts which is based upon how do we improve patient outcome with the services we do, orthopedics, catheters spring to mind. So again, what I'm trying to say there is you're pushing an open door with us. So we're really keen to try and move in that direction. And obviously, people like Mike and I, we believe procurement should be influencing every pound spent non-pay within the system, and that's a lofty ambition. But again, it's directly tied to today and to this audience in terms of innovation and transformation. So we can just move on. I think handing over to Mike now in terms of the strategy and how that actually works in reality. Mike, sorry.
Yeah, thanks, Jim. Yeah, so I mean, this is just a simple slide really that's lifted from our Lancashire South Cumbria strategy document, and it's not all encompassing in terms of what we provide as a service and what levers and strategies we employ, but it gives an indication of the scale and the size of the agenda that we manage day to day. So, like I say, there's a few things missing out of here, such as, I mean, top of my head, sustainability is a huge agenda at the moment. The fact that we're anchor institutions within the Lancashire and South Cumbria footprint and have social value responsibilities around that. So this isn't all encompassing, but it does show the scale of what we manage with our staff base. And just to add a bit more context to what we do, we actively manage around £600 million of non-pay spend per year. We cut around 650,000 purchase orders, got over 2,000 requisitioners dotted around our 5 organisations who we interface with on a regular basis. And the supplier base is around 7,000 suppliers. So hopefully that gives a bit of an indication of the wider procurement and supply chain agenda that we manage. It's a big undertaking. We've got a number of big organisations that we cover, and the challenge that we're grappling with now is also the geography of our patches, somewhat, if not unique, is certainly a bit more challenging than it is for our colleagues in GM and Cheshire and Mersey, the physicality of the location. Okay, thanks, Jim. Yep.
You've gone on mute, Jim.
All my best work's done on mute, to be fair, Steve. All my best work's on mute. Yeah, so as Mike says, with the strategy, there's a real shift, sort of paradigm shift, as we start to look more at the transformational agenda, and that's where we need to tie into innovative ideas, new products we're not aware of, different ways of doing things. Is say that journey, you know, that Tony spoke about removing unwanted variation, huge thing for us. Why do we do that? So it's that more transformational, which has got our clinical colleagues at heart. So again, you can see what we're trying to do is link it to patient outcome, because that's the best value for money, and linking it to that from an innovation perspective is the most important thing to us. So it again should be an open door for it. We're also trying, as you can see from the previous slide, to really adopt a strategy which is you can't over communicate. It's really important to us, and again, I think that's a conscious thing which reflects what I found, as I said earlier, a sobering start to the meeting around, as somebody who's, you know, we might, two senior people responsible for procurement, to find it's that difficult to deal with is not nice to hear, to be fair. It's true, and we accept that, but we're actually trying to do something about it, which is the positive thing. And again, it goes back to, I'm not going to go through the every point, but what we're trying to do is to make sure that culture, that process of being more open to innovation, to new ideas, to new products, to new services, to different ways of doing it, to really push that movement around actually it should be outcome-based specifications rather than just actual activity. Kind of what we're desperate to hear. Steve, if you just go on to the next one, that'll be perfect. So with this one, what we're trying, I think the most important thing for Mike and I around this was this golden thread idea. You know, so to sell to us, you know, what we're looking for is relationship. It has to be built on relationships in terms of understanding, because we've seen at a glance in the last 35-40 minutes how complex the NHS is organised. I love the idea of describing it as a flotilla. Mike, again, for those that maybe don't know the area particularly well, I think Mike's highlighted it. We'll quite literally cover from Whitehaven in the north to Burnley in the south and east-ish. I think that's the right geography. I'm a foreigner, so I'm allowed to get away with it. I got it right. Mike nodded, so I must be right. And everything in between, you know, truly a diverse area with different needs. But again, so we need to be doing this on connected. So earlier on, I spoke about making connections and personal, because it will be unique and we need to walk you through it, because unfortunately, as you can see from the videos and from the various slides, it is a minefield and very complex, and needing an expert to walk through that and to advise will help. It has to be innovation centric. I think that reflects, is Mike's, you know, as we said, 198 million deficit. You know, so it has to be transformational. That will get our attention. That really will get our attention. And if we can look at that in terms of efficiency, in terms of price, it's irrelevant. It's about what does it affect our run rate. If it affects our run rate and it's at scale, it gets our attention and gets support. We've also, it's been picked up with huge, strong governance around what we do. And I think that's been touched on in practical terms around evidence and independent evidence and trial after trial. I do believe quite strongly that barrier of pilot after pilot after pilot is slowly broken down based upon the fact that we now monitor nationally through Model Hospital and other sort of national key performance indicators, unwanted variation. So what you're finding now with people like Mike and I, when we've got evidence for other trusts have adopted it, we come back to the point that Tony made at the start. There's not that variation amongst patients. So if it's good enough for a patient in Barrow, it's likely to be good enough for a patient in Blackpool. Again, I think I mentioned recurrent budget. That's really important too. So if we just move on to the next slide. Mike,
Yeah,
you
thanks, Jim. Yeah, that's great. Thanks. So, yeah, I mean, today what we really want to make sure that you take away is how to highlight opportunities to us, where to find opportunities that are out there, to make you aware of the structural changes that are taking place, because these are absolutely key to how we're going to be engaging with the supplier base as we move forwards. And I think Jim's already alluded to the fact there that the consolidation of procurement services is only a good thing for you guys. It will make it easier. It's not to say it's going to make it easy, never is, but it will improve things incrementally as we move forwards. We want to re-emphasize as we go through, and we already have the local relationships, and the development of those relationships is absolutely key. So you guys leveraging the innovation agency, Steve and the team can be an excellent conduit to get you in front of the right people across the procurement agenda in our region. And also to pick up on something Tony mentioned earlier, increasingly data and some of the technology around the data is absolutely key to demonstrating value. Tony mentioned, products and services, they have to meet a need, and there has to be real world evidence. I think the data side of things, big data, is becoming more and more important with that. And I think as we can improve visibility of benefits and reduce some of that, I think pilotitis that was referred to earlier, that's only going to improve the kind of time frames that it takes to get innovation and new product into the service. Next slide, please. Okay, so we haven't included all the links on here because it started to get very, very messy. So we've kind of just distilled this down, and we can share links with Steve and the team afterwards as to where you access some of this. But fundamentally, we publish all our opportunities in public domain. We obviously comply to the public contract regulations in all matters as well. We have adopted a national e-sourcing system called Atomis. You may or may not be aware of this. It's actually more than just e-sourcing for us. It's actually our contract management portal. It's our project management portal. It's really becoming the only game in town in terms of how we manage procurement as a service. But there is a public domain element to Atomis that you can certainly access, and we can share information on that. There's also some legacy systems such as Finder, Tender, Contracts Finder, and again we'll share links on that. And most importantly, we think, and just to re-emphasize, is that our team can actually help you navigate your way through this. So we're happy to field questions and give you, the right points of contact within and across organisations in the patch.
Guys, that's great. Thank you for that. I think that's the last slide coming up now.
Yeah. Okay. So yeah, I mean, I think we've already covered most of this off really. I think the key thing is, Jim's already mentioned, we want to work increasingly collaboratively with you guys, with the supplier base, and anything that can improve the patient experience, anything that could make us more efficient as a service, we're interested in. So it's really, get your thinking hats on. We're happy to support you in any of that journey as far as it's practically possible. We'll do that. And please use Steve and the team as a gateway in as well. Thank you.
Okay, that's great. Thank you. Listen, can I just say to the delegates, there were 63 of you, 45 minutes, there's still 59 of you. So I'm really glad to see that retention rate. Just stay on because we've got Richard next from ABHI. And if we've got time, Richard, if we can just keep it to 5 minutes, I would like to open it up to any Q&A, and then I'll do a 2-minute summary at the end. So thanks, Mike and Jim. If you're ready, it's over to you, Richard.
Great, thank you very much indeed, and thanks for the invitation to be here today. It's particularly pleased to be with this group. I do, you may be able to tell from what's left of my accent, I do hail from the northwest coast, so it feels like I've come home for an hour or so at least. If we have the first slide, please. I promised to do this in 5 minutes, and I want to try and give you an idea for those of you who are not members of ABHI, how an industry body works, how we bring some of the stuff together. And many of you are starting your journey, may not even understand there are things such as industry bodies. So we're a member organisation. This is what we do. We probably the most important thing we do is act as an interlocutor between government and the industry. And everything you've heard today, you've heard a very operational view of the world today, but alongside the operational bit, there is also a policy piece as well. And we work very, very hard to shape policy through standing platforms with government, but also with government organisations. So just building what we've heard today already, we're doing a lot of work with the Department of Health and Social Care, their MedTech Directorate, about value-based procurement. People talk about, but we've heard a little bit about that today. People talk about value-based procurement. What does it actually mean? What does it actually look like? What sort of criteria do we need to look at? We're also looking at ways that we can make pathways easier to access the service. We've heard already Flotilla. It's a very complex organisation. Someone made the point I always make. The NHS is a lot of things, always has been. One thing is not national. And we're also working with NHS England on an innovation ecosystem pathway, an innovation programme. So how do we make things simpler? And the network of health innovation networks, the network of HINs, is crucial to that. We were set up 40 years ago to do stuff in regulation, to address new regulatory requirements. There is an awful lot going on with new regulation, new regulatory arrangements, both indigenously in the UK, but also in Europe. If you don't know about that, then you need to come and speak to us. This is part of our programme of NHS engagement. We have deep relationships with various bits of the NHS. So within recent weeks, we've been to Nottingham, we've been to Imperial, we'll shortly be in Sheffield and Birmingham and Manchester with NHS organisations to help you navigate things locally. Great networking opportunities through our member groups. And also, if you joined us, all you ever did was read our insight and intelligence, you will do better than your competitors because you'll understand the environment better. That is data, that is analysis done by the industry for the industry. And we also support companies to export. Next slide, please. So these are our priorities. I'm not going to go through these in details. We have two overarching priorities: growth and regulation. I've mentioned regulation. Growth is growth of the sector, companies and individuals within that, but also growth of the system. How can technology help the system grow its capacity to serve the patients? A couple of things I'll pick out on there. Sustainability hasn't been mentioned today, but if you want to supply the NHS, you need to align with its ambitions on sustainability. We have a programme which we can help people through that journey and a framework, a roadmap of what you need to do, by when, and who can help you. Then a little bit about quality, diversity, inclusion. We can help people on their journey as organisations, but also we're looking at how can we as technology try and address some of the health inequalities, which are obviously some people are working so hard to address, and certainly not exacerbate them when we think about things like digital inclusion. Broadly representative of the industry, 80% of our members are SMEs, but our 400 members account for probably 80% of the volume of the industry. And the next slide, please. This is a shameless plug. If you are at all interested in doing exporting, please come and speak to us. If you're all interested in doing business in the US, the most cost-effective investment you will ever make is to join our US accelerator. Please do come and see and talk to us. Hopefully someone will put something in the chat about how you get hold of ABHI and if you want further information. And then the final slide, please, Steve, is just going to be, this is how we're organised. Two messages from this. The way we organise ourselves through our functions and our business areas means that whilst we have breadth and scale, so we represent the industry in the widest sense, so medical devices, diagnostics, from IVDs through to imaging, through to digital health technologies. Whilst we have that breadth, which gives us scale, which gives us credibility, we also have focus. So I've got colleagues on who focus on digital health and on medical devices, but we also have that strong focus on diagnostics and international. There are some of our stakeholder engagement. You will see top right-hand corner there. one of the most important relationships we have is with the health innovation networks. We've been outspoken supporters of them since their inception. As was mentioned at the start, I chaired the Southwest HSN, as was at the time. My boss was the inaugural chair of Manchester HSN at the time. We're both still involved, formally in roles with West Mids and Oxford, respectively. But we do have a memorandum of understanding with the HINs, and we will be appearing at webinars like this up and down the land over the next year, and we're also very happy to support the outputs of the network. So thank you to those ABHI members who've taken the time to join today. And I think, Steve, that's my 5 minutes.
Yep, thank you. So 8 minutes to spare, so thanks to our speakers for rather slick timing today. I've got a little summary at the end, but if there are any questions, just raise your hand and Phil or Mike will bring you in.
So we've got some questions in the Q&A box. There aren't any in the chat at the moment, Steve. So do you want me to take you through those?
Please, if you don't mind.
Yeah, sure. So Joanne Hall has asked, what methods would you like to see to demonstrate health management, health economics influencing what you procure, and what horizon time is important to you? So I think that might be to Jim and Michael.
Okay, yeah, good question. I think understanding, so the product service, actually understanding what I'm going to use the word downstream benefits would be. It's probably the wrong sort of word, but for the point of the answer, it's about understanding exactly what it's going to change in terms of patient outcome. So for example, a few years ago, Mike and I were involved in a project which was for silver line catheters, which we could, the evidence from the supplier when they were new to market was overwhelming that it reduced infection rate, and that's, so for us that's really important, because we can then translate that into efficiency, patient benefits, all the good stuff, and then look at the cost of it. And that would be my, just conscious of time, that would be a pretty short summary of it. Horizon, one of the things that we do is we publish our workbook, and again it gives an opportunity to see what the areas we're looking at, to see if there's a match on that. But again, if it's something which could trump that, Mike and I are really happy to amend that to look at something that gives a bigger return for in terms of benefit for us as an organisation.
Thanks, Jim. So not a dissimilar question from Stuart Short, and this is about when to engage with procurement. So if an SME is at the stage of preparing a feasibility study with a health board, is it too early to start thinking about procurement?
No, we might want to come into this one. My personal views is quite strong in this one. I think it is as early as possible, even at the planning stage. But because what that allows us to do is to identify what we think may be the blockers, to advise this is maybe the route you want to navigate through. Mike, what's your thoughts on that one?
Yeah, well, yeah, the simple answer is as early as possible at all times. It's the biggest bugbear of procurement professionals is not knowing, finding out late in the day, finding out that the spec's already been locked down, or whatever other kind of maverick purchasing decisions made by that point in time. So no, as early as possible is the simple answer. And if sorry, if we could just go back to Joanne's question as well, just to quickly reference that, conscious of time. Value-based procurement was mentioned earlier as a project that NHS supply chain have been running with, and I think that for me that's key in terms of understanding the wider economics of how we procure. And I think value-based procurement is a bit of a misnomer. It's really what supply chain have been looking at there is procurement for pathways and not looking at product in its silo. So understanding the full patient journey, understanding how product and service can impact on the efficiency and the experience of that patient pathway is key. And I think we're engaged with that process, and we want to kind of make that as business as usual for not just the NHS supply chain element of what we procure, but also what we procure directly as well.
Right,
I can't see the Q&A, Mike. How many more?
There's another 3.
Okay.
So this one's from Simon Talbot. Procurement colleagues very positive about engagement. So I think that's, you know, what they've been hearing today. But who should we contact in the first place? So Simon's particularly interested in his product is obviously, you know, something he wants to sell to Acute Trust. So he's asking, you know, who's the first person to contact?
I think the first instance would be Mike and I. We have bravely put our email addresses on the very last slides, which Steve's going to circulate, I believe. So I think we need to put our money where our mouths are. So Mike and I have, as I say, very bravely put our email address on the back there. So in the first instance, you contact Mike or I, and that allows us to look at it as opportunity and then signpost accordingly, or to pick up individually or whatever.
Tony, I'll come to you at the end.
I think I would all. Sorry, Steve. I think I would also say that we're, you know, perhaps that we're also somebody that that we, you know, that companies can contact in the early stages as well, because you made the comment about, you know, what door do you go through? You know, we can certainly help with some of that, and so yeah, I would also add that to the mix. I know Tony's got his hand up. He's probably going to say something.
I was going to make that exact point, Mike, and we'll be working closely with Jim and Mike is so that you guys, the SMEs, etc., see us as part of a continuum, and yeah, exactly that point, Mike.
Any other two questions come forward, or do we not ask them offline, or?
Yeah, just a couple. Oh yeah, so could you share contact details? This is quite a big one from Craig Wood. Numerous frameworks out there that make it easier for both NHS bodies and vendors to do business, with some frameworks that allow ICBs to direct award without having to go out to full tender, which takes up a great deal of time and resource for parties involved. So, however, there appears to be a hesitancy from NHS procurement teams to do this direct award, despite it being allowed. So obviously some perspective is required there. I suspect this could take quite a long time, so maybe it's one to come back to offline.
So it was from Craig, right? Have we got Craig's surname?
Yeah, Craig Wood. Yeah, Craig Wood.
Craig, trust me, we will make sure Jim and Mike comes back to you offline if that's okay. Yeah. I've only got 2 minutes left. Was that the last question?
There is one more. How can we improve the often awful ITT documentation and standardise it?
Yeah,
that's another workshop.
Yeah.
So I just want to close this down with a minute to go. So first of all, thank you to the speakers. You've been great. And my colleague Phil in the background for helping me organise and run today's meeting, and Mike also for managing the chat and the Q&A. It makes my job a lot easier chairing a meeting like this. So I just wrote one last thing I wanted to leave you with. I hope you've learned something new today. So if you tell your partner or a colleague that you've learned something new today, that's great. But I also hope that you're encouraged by the genuine offer by the people you've heard speaking today, and it is genuine. And they're bloody NHS and industry experts, so you'd be mad not to speak to them. Would you speak to someone who's been up Everest before you went up yourself? Of course you would. So you can see what I brought you back to, that little picture. We can help you navigate the NHS landscape, and we can get you in front of the key stakeholders who are curious and care about solving a problem or driving continuous improvement. So I'm going to leave you on that positive note and say thank you for attending. We'll send all the slides out, and thanks again for everybody presenting.
Thanks, Steve. Thanks, everybody.
Nice one, guys.
Thank you. Thanks. Bye-bye.